2, 3. You can go live now.
Good evening, everyone, and thanks for joining. My name is Rishi Khartare, and on behalf of Hetero Healthcare, I welcome you all to the webinar on post-COVID-19 complications, management options, current and newer perspectives. COVID-19 virus is evolving and mutating. Not only it is affecting lungs, but is causing various post-COVID complications. We at Hetero Healthcare have always been in forefront and along your side in this fight against the deadly virus. Our esteemed and experienced doctors will share their experiences on the subject. With further ado, let me introduce you to the moderator of the webinar. It's my privilege to introduce Dr. Kshitish Roy. Well, Dr. Kshitish Roy, he's a super specialist in allergy, asthma, and clinical immunology of Dr. Roy Health Solution Multi-Speciality Clinic in Bandra, Mumbai. He is a former medical director for the esteemed Dr. Nifarkar's Asthma and Allergic Health Clinic in Dadar, Mumbai. He was associated with it as a senior consultant, allergist, immunologist, and asthma specialist. Prior to returning to his hometown of Mumbai in 2011, he was a senior consultant at Columbia Asthma and Allergic Clinic in Vancouver, Washington, where he managed 3 busy clinics seeing both children and adults with a variety of allergic, immunologic, and stress-induced disorder. Dr. Kshitish Roy has also been an associate professor of pediatric and medicine at the University of MS Medicine Center in Jackson, and where he also served as director of Jackson Medical Mall Allergy Immunology Clinic from 2002 to 2010. Dr. Roy received his Bachelor of Medicine and Bachelor of Surgery degree at the Seth GS Medical College from the University of Bombay at 1996. He then completed a residency in pediatrics at the University of Illinois Hospital at Chicago in 2000. He went to complete a fellowship in allergy and immunology at the National Jewish Medical and Research Center of the University of Colorado School of Medicine in Denver in 2002. He has also authored a number of articles and publications for leading medical journals, as well as books, a chapter titled Stress and Allergic Diseases for the Volume 2 textbook, Psychoneuroimmunology, 4th edition, 2006. In addition, Dr. Roy has been a diplomat of the American Board of Allergy and Immunology, a co-giant aggregated by American Board of Pediatrics and American Board of Internal Medicine. He's a fellow of American Academy of Pediatrics and American Academy of Allergy, Asthma, and Immunology, and American College of Allergy, Asthma, and Immunology. Dr. Roy was listed in Best Doctors in America from 2005 till 2010, and again in 2011 and 12, as well as in the Guide to America's Top Physician from 2005 to 2010. So I welcome Dr. Roy and invite him to take over the session. Over to you, Doctor.
Thank you very much, Rishi. Appreciate it, and thank you for the very kind introduction. It is my great pleasure to be with you all this evening. A very special warm welcome to all our delegates, to our panelists, and to Hetero Healthcare for organizing this webinar, which is much needed and so important in these COVID times. I'm just going to have a very short presentation that I will now share, through which we will just get a little bit of a background before we begin our actual panel discussion. So COVID-19 clearly has had a major impact on all of our lives in the last year and a half. And today, to discuss with us the pulmonary perspective of that, we have Dr. Prahlad Prabhudesai. From an intensivist perspective, we have Dr. Harish Chafle. And from the neurology perspective, we have Dr. Girish Soni with us today. Dr. Prabhudesai may be well known to a lot of you. He's a fellow of the American College of Chest Physicians, a member of the European Respiratory Society and Indian Chest Society, a DNB teacher at Leelavati Hospital, and also a course director for bronchoscopy at CMAST. So a very warm welcome to Dr. Prabhudesai. Dr. Harish Chafle is a consultant intensivist, a chest physician, a bronchoscopist, a sleep disorder specialist, and intensivist. He is a consultant intensivist, chest physician, bronchoscopist, and sleep disorder specialist at the Global Hospital in Parel, Mumbai. He completed his MBBS from Indira Gandhi Medical College in Nagpur, his DTCD from Government Medical College, Nagpur in 2004, his DNB respiratory medicine and diploma in fellowship in critical care medicine from Jaslok Hospital and Research Center in Mumbai. And he has over 15 years of clinical experience in critical care and respiratory medicine. He has great expertise in the area of critical care pertaining to respiratory medicine. Again, a very warm welcome to Dr. Shafle. Very happy to have you with us today. Dr. Girish Soni, an associate professor at Sir JJ Group of Hospitals, GGMC Mumbai, a consultant neurologist at Leelavati Hospital and Wokhart Hospital, and author of 3 books in neurology field, more than 20 national and international publications. He has received the Best Assistant Professor Award at JJ Hospital and GGMC Mumbai. He's a member of IANCON and MAN, also a young faculty national awardee in the field of neurology in 2012. A very warm welcome to Dr. Soni also. We are looking at coronavirus, which is an old foe in a new garb. We've had them around since the 1960s that we first recognized them causing common cold. Then we had SARS in 2002-3. We had MERS in 2011-12. And now we have the novel coronavirus 2019, which has really changed the way we look at this world and in many ways how we treat and deal with medicine and our patients. This virus belonging to the BetaCoronavirus family is 25 times larger than the SARS virus and is much more infectious. We know that the R0 for the original virus, if you may call it the alpha variant, was about 2 to 2.5. What we know about the Delta variant, which has now overtaken about 100 countries around the world, is that it has an R0 of almost 5, which is twice as much, or it's 100% more transmissible to people. The entry, as we know, occurs through the angiotensin converting enzyme 2 receptor, which is present in everywhere from the lungs to the respiratory tract to even the supporting cells in the olfactory bulb, is how people lose their smell, to the esophagus, to the cholangiocytes, the myocardial cells, the brain tissues, including there is something called neuropilin-1 receptors through which it enters the nervous system. So really a virus that can enter any system and cause a myriad of problems. Looking at the most recent data, we have had over 30 million cases in India. We clearly have had a fair share of death, over 4 lakh, and I'm sure everyone agrees this is an underestimation. We know that there is a wide vaccination schedule going on around the world, but we still have only vaccinated 0.3 billion of our world's 7.6 billion population. So we are very far from what we would consider to be herd immunity. Clearly, some countries are doing better than others, but we are certainly in the lead when it comes to the number of vaccines administered. So something in our favor and positivity. The primary symptoms, as we know, can be congestion, runny nose, loss of taste or smell, headache, cough, sore throat, fever, body ache, chills, muscle aches, shortness of breath, nausea, vomiting, symptoms appearing on an average 4 to 5 days after exposure. And where we used to believe that 15 minutes was required for exposure, now we realize that exposure may be as short as a few minutes for this virus to transfer, especially the Delta variant, which is very, very efficient in transmitting with much lower what we call viral loads required for transmission. It can present asymptomatically in 40% people, pre-symptomatic, symptomatic, as we've discussed, and amongst the variety of systems, ocular, cardiovascular, neurologic, psychiatric, cutaneous, all of these systems have been involved and really has shown that this virus can penetrate every tissue in the human body. Clearly, the therapies have been there and they have a variety of different options that are available to us, which we will discuss more in the subsequent phases of this panel discussion. We know that there is a viral response phase and then the host inflammatory response phase. And in both phases, damage can occur due to an overzealous immune response and also due to an underactive immune response. So there's an early infection, a pulmonary phase, and then a hyperinflammation phase, which is very much there. Recognizing that simple things like antivirals and then steroids can go a very long way if used at the right time in the right way. The variety of clinical features and biomarkers are also mentioned on this slide, which can be followed and looked at in these patients. When we probe the long-term sequelae, we know that SARS-CoV and MERS also impaired the diffusion capacity of the lungs, caused many other post-traumatic stress disorders, depression, anxiety, too many other problems that were there. The pulmonary sequelae with diffuse alveolar damage, platelet fibrin thrombi, coagulopathy, hemophagocytosis, and immune depletion were all features in how the pulmonary sequelae would occur. We are going to talk about cases later, but just this one case that Dr. Prabhu Desai had shared with me, where a patient, 57-year-old with dry cough, had these abnormalities, mild restrictions, severe reduced DLCO, post-walk desaturation of 4%. Remember, we look for bigger numbers, 3 to 4% or higher. And this patient, a month later, without any therapy, also showed improvement on the CT scan. So clearly, there are people who will recover without therapy. And clearly, as we will discuss, there will be people who recover and need a lot of care and intervention to improve. The extrapulmonary manifestations of COVID-19 is not something that I need to tell most of you all, but clearly there is a long list. And within this list, we also have things like mucormycosis, which I have seen occurring in patients who have had asymptomatic COVID-19 and subsequently directly presented with this disease, suggesting that there is a lot about the deep vein thrombosis, a lot about coagulopathy, and a lot about immune suppression that this virus does that we are still learning, because this patient never received any sugar, any steroids, never had any hyperglycemia, and still developed mucormycosis. And these were young patients in their teenager and young adults. So clearly a lot we need to know, and we're going to focus on the neurological, the thromboembolic, and the pulmonary issues that we are able to see today. There's clearly something called long COVID syndrome, and in long COVID syndrome, right from brain fog and persistent loss of smell and taste to all the way encephalopathy and stroke issues are there. Pulmonary with dyspnea, cough, chest pain, post-COVID lung fibrosis, which we will talk about. Cutaneous having urticarial rashes, erythema, persistent COVID toes. Psychiatric can range from depression, post-traumatic stress disorder, anxiety, social isolation. We are seeing more and more of this, and people are getting more and more calls about people facing these problems. Cardiovascular with palpitations, myocarditis, pericarditis, heart failure, and in general, we know about fatigue, myalgia being persistent for weeks, if not months, peripheral neuropathy, and peripheral limb ischemia. The neurologic sequelae, we've already said, the olfactory and gustatory dysfunctions are there. The respiratory virus infections are associated with a variety and a long list, as you can see, including cognitive impairment that may be seen. In all of this, before we get into the cases and the panel discussion, remember that focus on your own immunity, my doctor friends and colleagues. Take care of yourself first, because if you're healthy, then you can take care of everyone else. Fresh air, sunlight, exercise, there's nothing been like it in the whole wide world. And a good diet and rest when possible. I know it's easier said than done for some of us, but certainly focus on these things. So with this, I shall actually get into a case by which we will begin our discussion. This is again a case that Dr. Prabhu Desai has very kindly shared with us. This is a 57-year-old male, post-COVID infection, no comorbidities, complaints of breathlessness, dry cough, gastritis, SATs of 94% on 4 liters oxygen at rest, normal heart rate, normal blood pressure, respiratory system showing bilateral crackles. CT angio, pulmonary CT angio shows mild dilatation of the pulmonary artery, mild pericardial effusion, no thromboembolism, fibrosis with traction bronchiectasis. 2D echo shows severe pulmonary hypertension, left ventricular ejection fraction is maintained, thin rim of pericardial effusion, severe restriction with severe reduction of diffusion capacity on spirometry. with total lung capacity being reduced and post-walk desaturation of 9%, distance covered 260. These were some of the CT scan findings showing the pulmonary fibrosis, traction bronchiectasis, dilatation of the pulmonary artery, no thromboembolism, and after starting on antifibrotic therapy, the fibrosis became much clearer and honeycombing was very evident on the lungs. So post-COVID fibrosis with pulmonary hypertension, this was a case that had presented. And so from this, I shall stop my sharing and go to Dr. Prabhu Desai with the first question. Dr. Prabhu Desai, do you believe that the Delta variant or the newer variants of COVID-19 in the second wave have behaved differently than what the first wave that we had seen in India or other parts of the world? So your thoughts, Dr. Prabhu Desai.
Thank you, Sitesh. And I'm thankful to all of you to involve me in this discussion. Well, Delta variant and COVID-19 infection in the second wave is much more devastating than the first wave, okay, in many ways. First is that what I have seen is that a lot of younger patients getting affected, a lot of families together getting affected, higher mortality rate in some of the young patients, and very multi-organ failure happening quite early, okay, rather than happening later due to sepsis. Okay, then we also seen this other organs getting affected, especially kidneys, in large number of patients. Well, post-COVID fibrosis was also seen much more in this group of patients, and large number of patients also got infection like aspergillosis, mucormycosis, and CMV infection. So I think these are all things which we have seen different as a presentation also, and also sequelae also it was different than the first wave.
Very, very valuable information, and clearly from someone who's on the front line and dealing with this, I think it clearly shows that we are in an evolving phase of this disease with a lot of changes that are occurring. And we hope that there won't be a third wave with everyone taking their precautions and getting vaccinated, but certainly concerns are there. In the same line, Dr. Prabhu Desai, what would be the right time to do an HRCT, and how important is the score in evaluating these patients when we are starting to look for these early phases of pulmonary fibrosis or damage? And when should repeat HRCT scans be done, if any? And what should be the, what kind of risk factors would you say these patients have who are at risk for pulmonary fibrosis? Are there any red flags that we can look at?
Well, first of all, in our Mumbai city, we see a lot of patients getting admitted with first scan being done, okay, very early stage. I don't know whether it's really required or not, but these patients come with the scan, and this come with the scan with a score of between 1 to 7, okay, out of 25. And most of the patients come to hospitals like Lilavati and probably bigger hospitals with the scan. And I feel a lot of general practitioners are doing scans, and even patient demand scans. Okay, so whether they are justified or not, I don't know in the early stage, but certainly the scans have some role to play in predicting the severity of disease much before the hypoxia happens. You are all aware that hypoxia happens between the 7th day and 14th day, between that time, and the disease also is progressive, okay, during that time, with a significant impact on the lung. But if you see the involvement of the lung in early phase, which is higher, okay, we can predict that this patient is likely to develop a severe COVID pneumonia later on, okay, as the disease evolves or as the inflammatory phase starts in this patient. So yes, it gives you some idea, and this patient needs close observation, and they need sometime very aggressive therapy in the beginning. Sometimes I don't know whether it's justified to start steroid at early stage in those group of patients when they are receiving remdesivir or any antiviral therapy. But certainly those patients go later on become hypoxic and they require steroid at that time. So HRCT definitely helps to predict even the severity. Second, HRCT is certainly required if the disease gets prolonged and patients develop remain in the hospital for prolonged period of time. In severe COVID pneumonia phase, when they are on the NIV and high flow oxygenation, very difficult to send for the scan. Okay, but once they start improving their oxygen requirements, become less, and they are comfortable in lying down position, I think it's worth repeating a scan before discharge so that we can come to know the extent of disease, the possibility of developing fibrosis. Because I have seen some patient developing traction bronchiectasis and honeycombing much earlier than expected. Okay, so this patient can be diagnosed well. Third important reason of doing a CT scan is a vascular complication happening. In acute sudden breathlessness, who is really good, suddenly becomes breathless or severely hypoxic, or he develops hypotension, or he develops features like cardiac failure, or echo showing the cardiomyopathy, or probably maybe features suggestive of a right ventricular dilatation or a pulmonary hypertension. One should rule out thromboembolism in this patient, and CT pulmonary angio is required because it gives you a lot of idea regarding the management of this patient, and it may be a different. Third and fourth important reason for doing CT scan is post-COVID sequelae. Okay, when they come with the persistent fever, okay, for a longer period of time, or they become more breathless, which were not at the time of discharge, and the breathlessness rapidly increases. Okay, there your CT scan may guide us whether it's any form of liver lesions, infection, or whether a late inflammatory response in some of the patients, and which can guide us to therapy.
Thank you very much, Dr. Prabhudas. I think those insights are wonderful. And when you mention about the early scan being done, I recently had a patient of mine who shared a story of his 40-year-old brother who was in a fairly big city in India and had a CT scan on day 3 of his illness. He was febrile, didn't have too many other symptoms other than a little dry cough and a fever. His CT scan had a score of 0. And unfortunately, his RT-PCR came negative, and so did his rapid antigen test. And he was treated as having some other respiratory infection for about a week. And when about on day 9 or 10, his CT scan was actually done, he had a score of 21 and he was much worse. And despite a lot of interventions, his life could not be saved. So sometimes I believe the complacency that people get from having a normal CT early on can also be just as damaging as doing a CT around day 8, 9, 10 when it's really indicated and required, where we may get much more information based on some of the criteria that you said. So thank you very much for that. Dr. Chafle, I would like to come to you now. And my question to you is, being an intensivist, and clearly you have seen these cases evolve in front of your eyes and require your level of care in the ICU. What would you say are some of the red flags that you would want our audience to identify or know when you look at the progression of these patients from being a moderate case that's in the hospital just for observation because their oxygen sometimes dips a little down, to going into the ICU, being on a ventilator and literally battling for their lives? So are there certain biomarkers? Are there certain clinical features? What would you say is something that the audience can follow or look at in these COVID-19 cases?
At the outset, I would like to thank Hetero and the whole group who has arranged this. Thanks, Siddesh, for introducing in the beginning. So I'll take this question. First, we'll answer about the red flags. Definitely, whenever we have seen patients from the first wave till the second wave, the main factor which was responsible for seriousness of the disease was underlying immunosuppression in anyone. May that immunosuppression be related to the 60 plus age or uncontrolled diabetes underlying, or other comorbidities associated like hypertension, ischemic heart disease, and chronic kidney disease. We being a transplant center, we had received a lot of post-transplant patients who had developed COVID-19 infection. So all these factors are definitely red flags to see that these patients, even if they have initial mild symptoms, might deteriorate suddenly. to then extent that they will go to the ICU and they will go on ventilator. So actually, if these patients present early and if a care is taken early and you initiate the proper treatment, line of treatment according to their clinical status as well as their microbiology, their biochemical picture, then definitely we can produce a better outcome. As far as biomarkers are concerned, definitely certain biomarkers has helped us in knowing the underlying inflammatory status of the patient. I still remember a patient in Global where she was 38-year female. 4 days she kept at home that no, this cannot be COVID. She came to the ICU with a CRP of more than 100 and the interleukin 6 levels, which were around 88 and above. On admission, her oxygen requirement was 80% on NIV. She was in a cytokine storm. So if you do these markers, doing it on the day one is absolutely not going to help. Interleukin 6 and other markers have specific timings to be done. If you do it on time and identify the underlying cytokine storm, we gave her medicines, immunosuppressants. We gave her tocilizumab and remdesivir, and she started improving. Day 5, day 6, she from 80% FiO2 on NIV, rather than going on ventilator and invasive mode, she came down to FiO2 of 6 liters per minute. So definitely, if you do these markers, CRP, IL-6, your D-dimer values also will tell you how much is the prothrombotic load in these patients. If a patient has a D-dimer of very high, say above 1,000 or so, then you know that there is a prothrombotic state in this patient. If you don't initiate anticoagulant strategy early, then definitely these patients will go on to develop a pulmonary embolism or an acute myocardial infarction in the form of ST elevation MI. I had seen many patients developing ST elevation MI when we were on the rounds. The patient was improving initially, and 2 weeks down the line, ST elevation MI in front of me, the patient had a cardiac arrest and he died. We did everything properly. We thrombolized. We did everything that was required to be managed at that time, but we could not save the patient. So definitely these biomarkers are going to help us to know which patients are going to become bad. And so we need to do it at a proper timing and also see a trend of the biomarkers, because a single value will not tell you what is happening with the patient, rather than you monitor the trends as well as serial ABGs will tell you how the PaO2 is behaving, how the PaO2 upon FiO2 ratio is behaving, because less than 300 they come in with, and within 24-48 hours the PF ratio drops to below 100, and then suddenly the patient becomes hypoxemic and the further factors starts happening. So definitely these patients has these biomarkers which needs to be captured at early, and then you can come to know. Coming to clinical features which will tell you that these patients can become bad, we all have seen these patients being happy hypoxemic. The saturation will be low, but the patient will be very comfortable sitting across you, and suddenly within 24-48 hours they will deteriorate. So the chronology of events happening in this patient, how the symptoms have started, how they have progressed, and how quickly the oxygen requirement is going up will tell you that these patients are going to become bad. So if you catch all these red flags, biomarkers as well as clinical features, you are going to come to know that no, this patient is going to be, not doing good, and you have to keep on your toes and initiate treatment at appropriate levels so that you can make the patient better before he goes into a worse situation.
Great. Thank you very much, Dr. Chapley. I think that clarifies a lot of things. Just two follow-up questions to that for you. In terms of early anticoagulation, while in the hospital, while you're trying to prevent some of these thrombotic coagulopathic complications, what is the preferred agent that has been recommended? I understand most people have been suggesting low molecular weight heparin. Is there anything particular that you look at? And also the second thing is with IL-6 levels, there have been a lot of questions about people doing IL-6 levels from labs outside and having erroneous values and having issues, so something about doing these outpatient versus inpatient and how the samples are handled, I think is a very important message for our audiences to hear. So please do shed light on those two things.
Yeah. So first, the agent of choice, definitely, if you know that patient has a high D-dimer value, plus you know that this patient has high risk of venous DVT, basically, this patient is at risk of developing DVT, this patient has underlying comorbidities like diabetes, D-dimer value more than 1,000, and you know that this patient is at risk of developing DVT. Usually, enoxaparin is the agent which is widely studied, we have good experience about this agent, and you have to adjust for creatinine clearance for certain patients who have high creatinine values. So if the patient is in hospital, there is no question about DOACs. it has to be enoxaparin because efficacy. Otherwise, when the patient gets discharged and you have to continue something at home, which should be more comfortable and acceptable to the patient, then you can think of DOACs. But if somebody is in the hospital, you think that a thromboprophylaxis or treatment you have to give as far as prothrombotic events are concerned, then definitely it is enoxaparin, dose adjusted as per the creatinine clearance. Another thing about the IL-6 values, as you rightly said, I have my own experience wherein patient came with fever and he was very stable, no oxygen required, and his IL-6 value was 200, which was done in an outside lab. I definitely cross question because I cannot keep a patient of IL-6 200 in an OPD situation and manage him there. So I cross question and they were saying, no, it was properly done. Then when I went in details, the sample was collected somewhere on day one and the processing was done more than 24 hours later. So if you process the sample late, your IL-6 values are not going to match. Then the lab cross-check at some other level and then they definitely apologize to me and the patient that no, the IL-6 values were. So definitely it's not a single value. It has to be correlated with what the patient is coming to you with, how is the PaO2 is behaving, how much is the requirement of the oxygen of the patient. So you need to correlate everything together to form a common consensus what you are going to do about it. A single value of IL-6 is not important. Another most fallacious thing I have seen is people give tocilizumab and they keep on repeating interleukin 6 levels after giving toci. On the contrary, as we all know, tocilizumab is an IL-6 blocker. So if you give tocilizumab, next day the IL-6 values will definitely going to increase. There are 6 instructions in our ICU that if somebody has received tocilizumab, the IL-6 values should not be repeated at all. It's a strict instruction to the brother in the ICU because I have seen patients receiving 5 doses of tocilizumab because post tocilizumab the IL-6 kept on increasing and they kept on giving tocilizumab and then the patient came with severe immunosuppression. So all these factors needs to be considered and a single value is not important. The patient comes as a whole has to be assessed properly.
Great. Thank you. Thank you. Dr. Soni, I know you've been patiently waiting. I would like to now direct a question to you. These patients that we see with COVID-19 in the hospital who are getting admitted and even ones outside, we know that there is a significant neurological involvement in these patients. So can you shed some light on some of the common and uncommon neurological manifestations of COVID-19 that people really need to watch out for and look out for? Because these very patients that we've been talking about can suddenly have some very unusual manifestations coming up that can be very confusing to the treating physicians. So please, a little light on the common and uncommon manifestations.
Hey, let's divide this neurological presentation into ICU patient and OPD patient or ward patient. In ICU, common presentation, most common is encephalopathy, COVID encephalopathy. If the brain parenchyma is directly involved or MRI brain is abnormal, then we call it as a COVID encephalitis. So most common is encephalopathy, followed by encephalitis, then vascular affection, direct or indirect vascular affection leading to stroke. Most common being ischemic events, followed by bleeding. Bleeding could be parenchymal bleeding or subarachnoid hemorrhage. We are seeing both the things. Then next presentation, common presentation in ICU setup as well as OPD setup are movement disorders. Most common is COVID myoclonus, followed by Parkinsonism. Myoclonus and Parkinson, they are very common presentation or common feature in COVID people, both serious as well as non-serious patient. And in ICU setup, common are hypoxic brain injury or anoxic brain injury because of prolonged hypotension or prolonged hypoxia. Then peripheral nervous system, the problem because of involvement of nerve or muscle, they are also common in ICU setup, like critical illness polyneuropathy, particularly in elderly people, diabetic people, or those people who need prolonged sedation. And then GBS, Guillain-Barré syndrome or AIDP. Then uncommon in ICU are status epilepticus, autoimmune encephalitis, and myelitis. In OPD setup, the common presentations are headache. The patient can present even without fever, without common cold, only headache, seizures, myalgia, vertigo, and then the affection of the cranial nerves. The most common cranial nerves is number one cranial nerve loss of taste, smell sensation, followed by loss of taste sensation, Bell's palsy, sixth nerve palsy or diplopia, and isolated neuropathy like ulnar nerve palsy, median nerve palsy, or foot drop. The uncommon OPD manifestations are weakness or myopathy, ataxia, syncope. The syncope are, we are seeing a lot of syncope patient, particularly curb syncope or micturition syncope in young patient. Even GBS, isolated GBS as a presenting feature of COVID. Then post-COVID also we are seeing a lot of cases, particularly COVID, post-COVID autoimmune phenomenon, autoimmune strokes, autoimmune dementia, autoimmune myelitis, autoimmune neuropathy like GBS, autoimmune cranial nerve neuropathies, etc. Of course, mucor can be seen at any stage during active illness or as a post-COVID presentation.
So clearly, I think you have very nicely and extensively highlighted how invasive this virus, and if
Yeah.
not the virus, the immune response to the virus can be, because I think as an immunologist we have always seen the association between a viral infection and after a viral infection, because the immune cells are responding to your own cells that are carrying the virus. It sometimes does not know where to stop and start affecting the cells themselves, and before you know it, the virus is no longer there, but the damage continues because of autoimmune responses and prolonged responses. And as we know, there can be viral shedding up to 40, 50 days after an infection, because some parts of the human cellular machinery is still making parts of the virus that got incorporated into the genetic material. And the body can keep responding to it and having these very weird manifestations. And clearly this virus is very, very obviously showing us these things in every single organ system for that matter. So coming back to you, Dr. Prabhu Desai, I have a question for you. Do you think that post-COVID fibrosis or post-COVID interstitial lung disease can really be prevented? Can something be done so that this does not progress? We clearly spoke about picking it up early so that we can do something about it. But do you think that there are any interventions that can be done so that this disease does not impact the individual as much? So while in the hospital and also post discharge, are there certain things that you think could be taken care of or done so that this disease does not impact people as much as it is currently happening, and they're showing up later with more severe problems?
Thank you. First of all, there is no confirmed data on this, and there is no published papers and proven facts over there. But the observations are there, and probably the data may come later on, but certainly certain things are observed. Now, which are the patient who has got high-risk patients to develop fibrosis? If you ask me this question first, then I can tell you, if you detect this patient having COVID pneumonia, we have to be careful. Okay, then probably it may prevent fibrosis, or we be able to take care of this patient well. Like for example, elderly person, okay, if you are suspecting COVID pneumonia, okay, we should diagnose this patient early. That's very important. And antiviral therapy has certainly a role to play in the beginning, or maybe I don't know whether this is just my possible observation, whether we can think about a cocktail antibody giving some of this patient early may probably prevent high-risk patient to develop progressive fibrosis. Okay, so high-risk groups are elderly, smokers, chronic alcoholic, or a patient who has underlying lung disease, like suppose they have got early idiopathic fibrosis, or if they have chronic lung fibrosis following various conditions like hypersensitive pneumonia or collagen vascular disorder, or malignancy, anti-malignant drugs if they have taken earlier and they have some amount of fibrosis. From these patients, if the virus infection happens, definitely the viral they are vulnerable for developing progressive fibrosis. Similarly, a patient who has got a genetic preponderance for developing fibrosis, a familial lung fibrosis, also they will be they can get a progressive fibrosis following the viral infection. Similarly, the male patients who has got a severe COVID pneumonia have much more chances of developing lung fibrosis compared to female patients. So all these patients should be diagnosed early, and we should methodically treat them antivirally. The first week is very important. Giving antibodies in the first week, probably first few days, so that they will not progress to lung fibrosis. But if the patient has already now admitted in the hospital a severe COVID pneumonia, okay, or patient who require mechanical ventilation or NIV or a high oxygen for a prolonged period of time, sometimes oxygen toxicity also leads to fibrosis. So these are the patients who are likely to develop fibrosis, and this patient probably should be treated with anti-fibrotic drugs early. This is what I feel. Because anything, if you want like to give anti-fibrotic drugs, there is no point in giving in advanced stages, because if you see the early you treat, the results can be better. That's a very clear cut, though there is no evidence, but this is a thing which we can think about. Anything which we do early, intervention early, results are better. But even in the nintedanib trial, if you see that the early results, you can get it. If and the graph separates out very early, even in 2-3 months of therapy of nintedanib, compared to if you don't give it to the patients. Okay, so definitely early intervention can help, but it is too early to say. There will not be proven data on that.
In terms of choice, Dr. Prabhu Desai, is there any preference between using pirfenidone versus nintedanib? Do you think that there is any difference in the outcomes, or in terms of choice? Is there a reason why one agent would be selected over another? There are any advantages or disadvantages? Whatever we know from the ILD literature, and now through the post-COVID lung fibrosis literature, is there anything to direct that choice, in your opinion?
Well, I think little pirfenidone has got little more methodology of action. Okay, that is the mechanism of action from anti-inflammatory to anti-fibrotic. So probably it may have some age, but nintedanib also is really a good drug to have got an action against anti-fibrotic. So there is no clear-cut data, and I can say that the data can come out from India only, because both the drugs are available very easily in our country, and it is comparatively much cheaper, and there are no trials in India. Don't need trials to really start the drugs, which there are no proven data. Still, we give the medicines. That's why the data, if it comes, it will come probably from us. My experience is that both the drugs work equally good. Side effect profile also is equally good. Okay, we initially thought when we are giving low molecular weight heparin and we are giving anticoagulants, the nintedanib has got a much more chance of developing toxicity like bleeding, but which we never actually observed in practice. Similarly, we felt that pirfenidone will give much more side effect, because we step up the dose of pirfenidone very rapidly. Actually speaking, in practice, we give pirfenidone very slowly. We increase the dose from 200, 400, 600, 800, like that. But in COVID-19, we have started in the beginning itself with 400 milligrams 3 times a day. If there are no side effects in 4-5 days, liver functions are normal, patient tolerates, we straight away jump to 801 milligrams 3 times a day. We have not seen side effects. Really speaking, most of our patients tolerated very well. Liver enzymes were elevated in few patients in both the groups, but after stopping it and restarting it, we have not seen really enzymes rising. So both the drugs have got really equally effective, and that's what I'm observing. And the side effect profile also is more or less same. So anything you can start, but messages I would like to give that there is no point in starting anti-fibrotic when there is a honeycombing and when there is a traction bronchiectasis already developed. Okay, this is actually an indication that patient has developed a fibrosis. But most of our patients, when there is extensive lung injury, they develop fibrosis. Okay, there are organizing pneumonia and fibrosis. Both you should be able to differentiate on CT scan, and you can either have a mixture of treatment of organizing pneumonia along with anti-fibrotic. Probably that may be a better answer. And Later on, you can take a call. When the decisions is difficult, especially when you have to discontinue the medicine. When there is an improvement is happening, whether we should discontinue or whether we should continue the therapy for stipulated time. These are all questions which are not yet answered, and probably in 1 year time we may be able to give you the real answers.
Completely agree. I think that's very well outlined by you, and I think the message is loud and clear that start early. That's the key. If you see the red flags, if you see the problems arising, and you have your serial CT scan done at the second time point, and you're seeing some of the changes that make you worried about potential risk for lung fibrosis, begin the therapies early. Don't wait for it to evolve. Like initially people were being told that, don't start it before it is 8 or 12 weeks. I think it's already too late by then, is what you would also agree now with what we know in the past several months, and especially in the second wave. Dr. Chafli, I'll come back to you with the next question. What I would like to ask you is, in relation to thromboembolism and coagulopathy, what are the kind of complications that you're seeing in patients admitted to the intensive care unit? And what kind of issues are they facing? What kind of, vigilance do the treating physicians need to have on that? And we've spoken a little bit about the medications and the intervention for it, but a little bit more on what kind of issues you're seeing.
So yeah, as far as the venous thromboembolism or prothrombotic state and associated complications are concerned in patients who are admitted to ICU. So if somebody is already on ventilator, you know that he's immobilized, his D-dimer values are high. So we usually start LMWH in the appropriate dose required for him. But what kind of patients we are seeing is, we have seen patients of stroke directly coming. We had a lady basically who completely comatose presented to us, and in 24-48 hours she was brain dead, and the swab came late and it was positive. So she presented with a prothrombotic state where both the basilas were completely occluded, and she had a massive stroke at home, became drowsy and came to us. So most common occurrence is pulmonary embolism, but it is very difficult to prove pulmonary embolism in patients who are on ventilator, who are on multiple vasopressor supports, and who are very sick to be shifted. In that case, a high D-dimer value with a 2D echo showing RARV dilatation and a clinical picture fitting into PE, which will tell you that the oxygen requirement is suddenly going high. And we have thrombolized also patients of PE without doing a CTPA, because clinically they were matching with the presentation of pulmonary embolism. But I'll tell you my experience while thrombolizing these patients of PE in COVID. In COVID, the quality of the clot is such that it does not get dissolved with any of the anticoagulants. I have used altiplase for PE and tenecteplase for acute MI, ST elevation. But in both the situations, I could not win over basically. So in certain patients who had very high D-dimer values, after seeing these trends in our ICU, we have started a protocol that if the patient's D-dimer value is more than 2000, then rather than giving them LMWH, we are starting them on heparin infusion, which is monitored with APTT every 6 hourly. And in our observation in global, this is found to be more useful, because then the D-dimer value comes down gradually. You can monitor APTT and you can titrate dose as per the requirement of the patient, and then the oxygen requirement in those patients who were having underlying PE, it improved. So as far as VT is concerned, then all these were presentations, and acute MI, stroke. Then we had seen patients with unilateral digital gangrene with occlusion of the peripheral vessel because of prothrombotic state. So that was also we had seen. And sinus venous thrombosis, patient presenting with status epilepticus directly, and the swab came positive. So there were several presentations like this, which corroborated with the prothrombotic state that is definitely there. And as we all know, there is endothelial damage, there is hypercomplementemia, and all these factors they make the patient more prothrombotic. And I think these are the main complications of COVID-19, and this is causing a lot of problems.
Thank you very much. I think that's very clearly stated, and I think you've taken us through the in a very short time the entire gamut of what this virus and its associated immune response can do. Dr. Soni, I think it's a natural segue coming to you, because Dr. Dr. Chafle mentioned both stroke as well as seizures. So in terms of strokes, what are you mentioned that there can be ischemic stroke, there can be hemorrhagic stroke. Can you mention a little bit about the management of these things when it comes to, and also the types that are there and the management, and how it may be different from other cases of routine generalized tonic-clonic seizure versus this patient with COVID presenting with it, and what are the specific features that you all see as neurologists that are important? So a little of your inputs on some of the complications that Dr. Chafle
Yeah.
just mentioned these patients can have,
In,
or I can say sequelae.
So number one, stroke. The stroke could be artery involvement or venous involvement. Artery involvement mechanism are endothelial dysfunction, direct invasion or direct affection of the endothelium by the COVID virus, or elderly patient with underlying diabetes, hypertension, some cardiac risk factor. So arterial ischemic stroke can be managed by a standard treatment. If the patient with a stroke within 4 hours, we can go for thrombolysis, and we saw a good rate of thrombolysis with this RTPA. If the stroke is within 8 hours or within 10 hours, we can go for mechanical thrombectomy if the thrombus is present in the big blood vessel. But most of the COVID stroke, we saw involvement of the small to medium-sized blood vessels. So usually we treat them with anticoagulation or double antiplatelets. Anticoagulation with single antiplatelet. If anticoagulation is contraindicated, then double antiplatelet with high dose of atorvastatin. Because there are many articles which says atorvastatin is useful as an anti-COVID agent also. So atorvastatin, no doubt, it helps in endothelial stabilization and everything. So we manage routinely this ischemic stroke. Of course, the other vascular risk factor we need to take care of, like hypertension, diabetes. Then other mechanism for stroke nowadays is mucor or vasculitis, autoimmune vasculitis. We are seeing lot of COVID, post-COVID patient presenting with stroke and showing the bleeding on the angiography. So here we use steroid or IVIG. So stroke as the autoimmune presentation of COVID or post-COVID complications also we are seeing, number one. Number two, bleeding, rupture of these blood vessels. The bleeding in the parenchyma or bleeding in the subarachnoid space, or even subdural hematoma, epidural hematoma are also we seeing. And most of this bleeding we can manage either by surgery, evacuation of the hematoma, craniotomy, and strict control of the blood pressure along with anti-edema measures like hypertonic saline, or if kidney is not affected, mannitol. We cannot use steroid in such situation for edema. Then venous affection. The venous affection is in the form of cortical venous sinus thrombosis leading to raised intracranial pressure syndrome. And this patient usually develop headache, altered sensorium, or they can present with seizures. And the best treatment is anticoagulation. Initially heparin, followed by oral anticoagulation. The data goes in favor of warfarin. Only recently in 2019, the data on dabigatran came. So we prefer warfarin over NOAC in CVT patients.
Got it. Thank you very much. I think
and regarding seizures, the seizures in COVID people, particularly in ICU patient, once they develop seizure, the seizures, they are not controllable with routine medication. Normally, we add 2 or 3 drugs simultaneously to control this seizure in COVID patients. Sometimes even with multiple anti-epileptic drugs, they don't get control. Then we go for CSF and we look for the autoimmune markers. If some markers are positive, then we go for high dose steroid, IVIG, or plasma exchange therapy.
you had earlier mentioned, Dr. Soni, about Parkinson-like presentation of these patients. Is this something that is there in the acute post-COVID phase, or is this something that then becomes persistent? Like, we see with diabetes coming up as a new onset in people with COVID, and then after they recover from the COVID, the diabetes is with them to stay. So is this the same situation when it comes to, because normally we had understood that it was more of a white matter and not so much affecting the nuclei and the ganglia so much. But if you're saying Parkinson's, then clearly it's affecting those areas also. So
Yeah.
what
Yeah.
is the literature right now in your field?
There is no clear-cut literature. Literature came on myoclonus. Most common presentation of COVID amongst movement disorder is COVID myoclonus,
Okay.
which nicely respond to piracetam, levetiracetam, or valproate drugs.
Okay.
Easily manageable. Regarding Parkinson, the literature is not that solid. We saw almost more than 40-50 cases in Lilavati only, COVID Parkinsonism. During active illness, even as a post-COVID presentation, it can happen. Number one, in almost 90% of people, it get controlled with a simple medication like Syndopa or Levodopa. But 10% patient, they trouble us. The Parkinson goes on progressing in spite of multiple medications. We still don't know whether there is some role of autoimmune mechanism over here and some role of steroid or IVIG or rituximab, tocilizumab. Not still look into that field.
Got
Only
it.
in one patient I used steroid as the patient was not getting control with the medications. And after steroid, little bit stabilization, better stabilization.
Are most of these cases that you've seen, Dr. Soni, elderly patients, or are they also people who are not as much as in the age range as you would think to be developing Parkinson?
Parkinson always more than 45, 50 age group. Stroke we saw even in young patients. Seizures, stroke, no age criteria
Got it. Okay.
overall.
Thank you. I think we have covered a lot of important topics today. I think there's one more question, Dr. Soni. I think it can be best addressed by you. Uh,
Yeah.
Even after recovery from COVID, when person is no longer having any problems, in long COVID, what is being called as the, sequelae, 8, 12 weeks after recovery, what kind of issues, you've mentioned some of them, but in long COVID, is there anything particular that you would like to highlight for the audiences to keep a watch out for? Or like
Yeah.
even for simple things like chronic fatigue, some peripheral neuropathy, things like that, are there some drugs or some therapies that can be beneficial in
Uh,
this long COVID?
Sir, basically neurology is such a means patient can present with any presentation. Number one, for vascular complication prevention, we recommend for at least 6 months to 1 year duration, double antiplatelet if the D dimer of the patient was very high during active COVID illness, more than 1,000. Then we prefer newer oral anticoagulant like dabigatran, apiximab, like drug for at least 6 to 1 year to prevent the post-COVID strokes. Number one. Number two, for neuropathy prevention, for dementia prevention, for Parkinson prevention, as such, we cannot directly start any drug.
Correct.
We have to look for the memory problem, behavior problem, personality problem for dementia. We have to look for weakness, proximal as well as distal, starting both upper limb as well as lower limb, progressing fairly rapidly. That is GBS, neuropathy. Then we need to act fast. IVIG or plasmapheresis and ICU admission for prevention of ventilatory dependence or for prevention of the respiratory muscle weakness. Then for cerebellar ataxia, for spinal cord involvement, for other cranial nerve involvement, we have to look for the specific weakness or specific cerebellar signs sort of thing. So any alarming new onset weakness, sensory symptoms, memory symptoms, we have to look for the underlying cause. And most of these causes are autoimmune mechanism.
Is there anything on the brain fog? A lot of patients, and I think across the world, people have said they feel like their memory is not as good as it was before they got COVID-19. So, anything in the neurology literature on that and how that can potentially be handled or managed?
Yeah.
I know that this is not a very specific question,
Yeah,
but
yeah, yeah.
it's something that is very high on the minds of a lot of people, because I know many of my patients who we treated, and have come back and they say that, we are forgetting things, we are not remembering things like we did before. And just the mental fatigue that they experience sometimes, even if they're physically not fatigued. So anything on this aspect and any intervention
Uh,
game for it?
yes, sir. Sir, post-COVID depression. It's very common. Almost 50 to 80% of people, they are developing post-COVID depression. If the depression is moderate to severe, usually in such patient, the attention is impaired. Their concentration is impaired because of depression. So most common cause of mild memory impairment in a post-COVID patient is depression itself, which is almost associated with fatigue, decreased interest, sleep disturbances, decreased mood. So we need to find associated all these symptoms. If these symptoms are there, for that memory symptoms, what they are telling us, I'm having some memory issue, straight away go for antidepressant. Number one. If there is no depression as such in the patient, as per other symptoms, and the relatives are also trouble with the patient memory trouble. See, what is real depression? Progressive memory loss, impairing the patient's social capability, economic capability, and decision-making capability. If the relatives are telling us he is having very bad memory problem, then it's an organic memory problem. So we need to look at the age of the patient, whether patient had previous comorbid subtle memory issue, then this could be exacerbation of underlying dementia post-COVID, or COVID itself causing memory trouble, and that is autoimmune dementia. Autoimmune post-COVID. At present, I'm having two patients of post-COVID dementia admitted in Lilavati. Autoimmune. Both are responding nicely to steroid as well as IVIG. So
And
last cause is autoimmune.
is there any role, because people are trying to give, the B1, B6, B12 multivitamins and all those things, any
Yeah.
role for all of these? I know so many people have questions on these things. Should we keep them on multivitamins, zinc? Should we be giving them more of vitamin D, optimizing it? Anything in
No.
relation to that?
No role. In fact, we are using lot of zinc tablet. Zinc impairs the copper absorption, and we are seeing lot of sensory ataxia post-COVID. And this sensory ataxia is because of copper deficiency, just like B12 deficiency.
Yes, yes.
So we are seeing lot of copper deficiency ataxia getting better with copper tablets.
Great, great.
No
I think
role,
this
no
is a
role.
very important message that I was hoping you would highlight, and you said it, because I know that there are issues with what is being done routinely out there. And I know patients who've been taking zinc tablets for a year and a half since
Yes.
the COVID began. I know people who've been taking vitamin D every week for months, and they
Yeah.
now have levels that are over 200. And when they come to us with the classic headaches and all the other issues, the first thing we do is we tell them to stop some of these things and
Yeah.
correct
Even during first COVID wave, COVID outbreak, the arsenic, many people consume arsenic very badly, and we saw almost 5 to 7 cases of arsenic toxicity presenting with psychosis, neuropathy, bad ataxia, anemia.
And I think this again is a classic example where actually the homeopaths wanted them to take it only 3 days in the month,
Yeah,
when people
yeah,
ended
but
up taking it
people take,
consistently and continuously, hoping that more of something is better, and ended up damaging themselves. You're absolutely right, because even that science has its role, but it needs to be done with guidance, not
yeah.
just randomly as people do. I think we've covered most of what we wanted to discuss. I will now start taking some of the questions that we have received. Some of these questions I believe that we have already answered, like um, role of antifibrotic drugs in COVID treatment, when to start the usage, and what should the duration and dosage be. I think Dr. Prabhudesa, you've already answered that very well. I don't think we need to get into that again. The next question is, what are the indicators of lung fibrosis? Is a high IL-6 or a high D dimer associated with a greater risk for lung fibrosis? Your comments, Dr. Prabhudesa. You're muted. If you can unmute yourself, please.
Okay, I have not really observed that. D-dimer elevated, though it's a marker of inflammation. I have not seen higher D-dimers. There's a more fibrosis. No. Similarly, IL-6 levels also not really associated with fibrosis. Yes, cytokine storm and IL-6 has some role to play in developing severe lung injury, but IL-6 cannot be considered as a marker for the developing fibrosis, because there are other inflammatory markers as well,
Exactly.
which are probably.
Certainly, things that we don't check for TGF beta, and there are several others of them that can cause this problem. So What is the right time to start antifibrotics and what should be the duration? I think right time to start you have already discussed. What is the duration? I think you also mentioned that it is not an easy decision when you start seeing.
Generally in COVID, when you have classical lung fibrosis like traction bronchiectasis, septal thickening, honeycombing, we should give at least for 1 year before we say that it is effective or it is should be or deciding whether to further continue treatment or not.
Okay. There's a question, what is long COVID syndrome? I think I already covered that in my presentation and we've already discussed it. Persistence of COVID related symptoms beyond a period of 6 to 8 weeks, sometimes into months, where the manifestations can be anything from head to toe, right from cutaneous to neurologic to cardiovascular to respiratory, is essentially what long COVID syndrome is. Next question is, what are the clinical experiences with NOACs? Dr. Chafle, would you like to take that?
Yeah, so actually,
yes, I think you just unmuted and then muted yourself. Yeah, there you go.
Yeah. So first thing is these are no longer called NOACs. They are not DOACs. We know this directly acting oral anticoagulants. So definitely our observation and clinical experience of anticoagulants, if in the ward the patient is not sick, you find that he has factors of risk factors for venous thrombosis as well as he has underlying comorbidities. Then I have used more of apixaban basically. Only thing that in favor of apixaban is its renal safety. If you compare all the DOACs, basically apixaban, rivaroxaban, and dabigatran. So all these agents, if you compare, then there is data for apixaban in patients of CKD on dialysis, but there is no data for other agents. So that's why I usually prefer single agent, which I can prescribe for all the patients if it matches the levels of the requirement. So definitely I have used 2.5 mg BD and 5 mg BD also if it comes to that. And efficacy wise, they were equivalent, but there are no direct studies to recommend this agent when the patient is admitted in the hospital. So that's why everybody is using enoxaparin. But there are patients who are very finicky that I don't want a jab on the tummy twice a day or once a day. In those patients particularly, and also there was an incidence wherein there was bleeding. There was basically bleeding at the site of LMWH injection. Two patients had such incidents in global, wherein they had a bleeding in the intraperitoneal hematoma had formed after giving the injection of LMWH, and then we literally had to do a CT angio and embolize the bleeder to salvage the patient because they became hypotensive and they were in shock. So particularly if you find that in the ward or the care cannot be taken or subcutaneous injection cannot be taken by a patient himself at home, then definitely these DOACs are going to help. So yeah, good experience and good efficacy, I would say.
And how would you rate? This is a question from one of the, they've said that, how do you rate rivaroxaban in this whole scenario? Is it also because I know a lot of people are being able to use it now outpatient? It is even being prescribed subsequent to discharge. So when getting discharged again, is there a particular choice that you would have? And I would like to ask this to the other panelists also, if they have any experience with rivaroxaban and its usage. So, but we'll start with you, Dr. Chafle, since you were on this question.
Yeah. So I have not used much of rivaroxaban because if you compare all the DOACs, the bleeding risk with rivaroxaban is more than the other agents. I have basically used apixaban only from the beginning of this pandemic till now. And I will not be able to tell more about rivaroxaban because I have not used personally in my clinical practice. But apixaban works wonders and it is safe also.
Got it. Dr. Prabhu Desai, any comments on the use of rivaroxaban?
I think it's an equally good drug, cheaper drug compared to the apixaban. And I find even single dose is good for a prophylactic therapy. If you are going to use it as a prophylactic or a post-discharge, 10 milligram daily or 15 milligram, quite safe. And I agree with him regarding the data on renal failure. The data is only of apixaban. And those group of patients we use generally the apixaban. But Other groups we can use safely this drug, and it is little cost effective for large number of patients. The cost is very important, and I feel this is cheaper drug compared to other anticoagulants.
Thanks for your input. Dr. Soni, any thoughts on, and I know you've mentioned the double antiplatelet agents versus using these kind of agents, the NOACs. So any thoughts related to this, to rivaroxaban specifically, and then also just in terms of choice of agents?
If patient has multiple vascular risk factor, if at the time of admission patient's D-dimer was high, then better to give patient NOAC. Amongst NOAC, rivaroxaban as well as apixaban, both are good. As Prabhu Desai sir said, cost single day therapy with rivaroxaban. And we found that with apixaban, the chances of GI bleed is very high. GI bleed and hematuria. So both are good, but otherwise.
Got it. Great. Yeah. Next question, a very interesting one. Is there a role of anticoagulants in home isolated patients? I'm sure what the person wants to ask is, when you have a high risk patient who is in the house, they have other risk factors. We know that COVID-19 can cause coagulopathy even in mild patients. Potentially, the risk is very much there. So is there any role to using oral anticoagulants at home if you're treating some of these high risk patients, obese, hypertensive, diabetic, but having mild COVID? Your thoughts on that? Anyone?
I think, first of all, the incidence of vascular complication in COVID is pretty high. If you see the data, it's around 16.5%. Okay. So with this in the high risk group, okay, it's just it is worth giving oral anticoagulants when you're treating at home. So I think we are justified in giving them. Only thing, we have to be careful when we give this patient, because we must know what other antiplatelet drug they are using, okay, before we give. Sometimes they are on your aspirin, clopidogrel, and they are in combination. And if you don't go in depth properly, you will not know, because some of this combination is also with atorvastatin. And we generally get mistaken. So many products are there. So we have to be very sure, and triple drug we should try to avoid. That's very important. And kidney function, and sometimes the liver dysfunction in them, chronic liver disease, they should not have underlying. So if you are going to consult the patient, okay, on web consultation, I think we have to be very careful.
Got it. Would you suggest any kind of biomarkers or any red flags to look at when we are starting anticoagulants at home? This is actually a follow-up question that came in. So any thoughts on that? Like, should people be doing, there are people who have what could be classified as mild COVID, but their D-dimers do get elevated. We don't routinely check D-dimers in mild COVID, but sometimes those panels are done and you find them. So in that similar way, are there any biomarkers or any red flags? Like we discussed, someone who's hypertensive, diabetic, he has heart problems, there are other issues, they have other comorbidities. Certainly, people that we would think about, but anything more specific is what one of our doctors in the audience wants to know.
I don't know, but D-dimer for a prophylactic therapy is an important biomarker, and especially if you are doing a rising D-dimer, okay, will be a really good marker. Along with, if the patient's CRP is high or ferritin levels are high, indicating is a pro-inflammatory phase. And if the other markers like platelet counts are normal, and if he's not a chronic alcoholic, or you are not suspecting any chronic liver disease in them, you should consider on that ground definitely a prophylactic dose for therapy, and you do monitor the D-dimer follow-ups.
Okay. Anything Dr. Chafle or Dr. Soni all would like to add to what Dr. Prabhu Desai said?
Dr. Prabhu Desai rightly said about this. The serial values are important. Ferritin, other things also can be added. Another marker which will tell you about severity will be a neutrophil lymphocyte ratio. NLR is definitely a very good marker. If you see CBCs properly in these patients, and all those patients who have very low lymphocyte counts have seen to be on the higher side of being seriously ill and other things. So that NLR is again a marker that you can pick up early and then come to know that no, this is going to be bad.
The next question is an interesting question, regarding the cocktail antibodies in COVID-19 management, your views. So I think the audience wants to know each of your thoughts on the COVID antibody cocktails that are now available for use in mild to moderate COVID, started early. And we have the casirivimab and the imdevimab that is currently available to us. Definitely a expensive treatment, almost 59,000 rupees for a dose. So each of your thoughts on the use of this and the timing for this, if you all may share.
Well, we are using it, but it should be used in very early stage of COVID disease. And it's first 5 days, I can say. And first 3 days is always best. And you should see them as patient should not be actually hypoxic. The oxygen should be normal, especially in this group of patient. And I can say that there should be high risk factors should exist in the patient to develop a complicated COVID pneumonia. Then this patient should be used in those group of patients. And yes, it's an open treatment, or we can do a daycare admission probably. We do actually hospitalize for a day for this because some of these patients are insured, so they get money when we admit the patient for that simple reason. But otherwise, it's an OPD treatment, and we can give this patient this cocktail antibody and say no. And we have done in a few high-risk group patients as an experiment. Okay, when my patient was vaccinated for COVID, still despite of that, patient had a COVID pneumonia confirmed diagnosis, febrile and all other markers, and there was no hypoxia, and we have treated with these antibodies and sent boldly home. Okay. Especially elderly people, they are best managed, at home rather than
at home. Absolutely.
And in early stage, admitting a patient, elderly person has got no meaning because first
Correct.
5-6 days they are nothing. Actually, they are just sitting on the hospital,
and they may actually acquire nosocomial infections.
Yeah, and I mean, it's and then the complication, if they have to happen, they should happen on the 8th or 9th day or 10th day, and then at the time we are discharging the patient, and then again some of these patients get readmitted. So it's best to treat them and educate them regarding observation and red flag signs in them, and then recall them for if they are hospitalization required. Okay, in the hospital. So I think it has got a role to play.
Great. Any thoughts from the other panelists on the use of cocktail?
We have used this cocktail antibody in global basically, but as rightly said, has to be early within 3 days, 3 to 5 days. 60 years and above is a group that I think most benefits out of this, and particularly you feel that to prevent the severe form of COVID. Patients who are immunosuppressed, you feel that they would become bad if you don't give them early. So all these patients, and it's too early to comment, but I have seen good response with this antibody cocktail with whatever we have used.
Right, and now it can be used in children above certain age, 12 years of age, pregnancy, and I mean these are something we can't give antivirals in this group of patients. So there's some
clear advantages, absolutely clear advantages, and I think it makes sense. And the only concern that has been raised is now, like we are hearing about the Delta Plus variant with the case 417N, which is evading some of these monoclonal antibodies. Unfortunately, there's still early data. We don't know how much, but there may be a 60-65% effect versus a higher effect if it was an older variant. So I think that time will tell. I'm sure that we'll have more of these coming in the future with more updated versions of these antibodies, but certainly in the right case, in the right situation, there is a role for them. The next question, I think, Dr. Prabhu Desai, will again be for you. Can we shift a patient from pirfenidone to nintedanib? Will it affect the patient's health, or will it help improve their situation compared to what pirfenidone was able to do? So is there any reason to consider switching?
Generally we switch the therapy because of the side effects actually. See now, nintedanib we have started and patient starts getting diarrhea. Okay, I mean that's a terrible side effect sometimes for the patients. Okay, especially when they are on hypoxic, they are on oxygen therapy, and getting a diarrhea frequently. They have to go to pass stools, obviously, and then during that time we stop the nintedanib and we shift to perfenidone, which doesn't have diarrhea as a side effect. They have other side effects, upper GI, and all that. But that is there is a rash coming on the perfenidone, which is not very common. But I have seen one patient who had developed a hypersensitive reaction and develop a rash, and I have to stop perfenidone and shift to nintedanib. So this thing can happen, Okay, otherwise, but if the liver enzymes are elevated in both this group, you can they are known to give hepatitis. Okay, liver enzymopathy, you can say. Okay, so but in those group of patients, we can stop and reintroduce a lower dose.
Got it. There's a question on newer molecules in COVID-19 management, molnupiravir and the baricitinib. Your views on that? Anyone can take that.
Yeah, baricitinib after that NEGM trial, we started using it. In fact, the day the trial came on the 3rd of March, I think. Hello?
Yeah, we can hear you.
On the 3rd March, the paper was there, and one of my patients has contacted me, very close contact, and said, why not you try that on this patient? And then we could manage to get, because it was available in India, okay, and we started using it. And when the tocilizumab is not available in some patients, okay, we started adding this drug along with remdesivir, okay, and when in the severe form of pneumonia, COVID pneumonia, it has a role to play. You have to adjust the dose in renal failure to 2 milligrams instead of 4 milligrams, which is normal dose. And you have to be careful, especially when you're giving steroids with this group of drugs. And you have to have a very small dose of steroids. You cannot give a very high dose of steroids. You have to be careful. Only side effect is I have noticed I have lost one patient. I don't know whether he's lost because of toxicity of that, but patient developed pancytopenia. After on the 5th day of the starting that drug. But we use the drug very commonly. Okay? It's not that only we don't know what are the different drugs can be added when you are giving these drugs. So that is something which we are not aware of it. Okay? And but considering the severity of COVID-19 pneumonia and ARDS, I think it's justified to use that drug after understanding the product.
Thank you. Dr. Chafle, any comments on molnupiravir or on baricitinib?
Yeah, so we have also used baricitinib in not too many patients I have experience of using, but few patients I have used, so it will be too little experience to convert it into an experience that is useful or not. But as rightly said, it has to be used initially with remdesivir, and this is the agent preferred where you feel that you cannot use steroid basically. So baricitinib with remdesivir initially as a combination. There are literature and data in favor of this, but I have not used in many patients, so I will not be able to comment about the utility of it.
Got it. I think molnupiravir, we are still having trials on them. We don't have it available really for our use. I think it is something that is being touted to be better than favipiravir, but only time will tell, because it's not a repurposed drug per se. But I think that we'll still have to wait a little bit to see what the data shows. I think we have pretty much covered most of the questions. There are a lot more, but many of them have been answered. There's a question about how do you titrate rivaroxaban between 10, 15 or 20 mg. Any thoughts on that? Do you start low and then go higher if you feel you need it, or do you start higher and then taper it down? Any thoughts on that? If any of you
any dose between 10 to 20 milligram is useful. Okay. We use 10 milligram particularly in those people who are 80 plus. Those who are in between 60 to 75 age group prefer 15 milligram or 20 milligram. 20 milligram we particularly use in those people who have evidence of atrial fibrillation, very low ejection fraction on 2D echo, or bad cardiomyopathy, or very high chances of any thromboembolism phenomenon. Otherwise, 10 to 15 milligram is enough overall. Yeah.
I think that sounds appropriate, and I think everyone would agree with that. Um, Again, I think we have really stuck to the time. We have 4 minutes to go before 9 p.m. So I want to thank each one of you all for really sharing your experience, your valuable knowledge, your frontline experience, as I would say, right there handling these cases. A very special thanks to Hetero Healthcare for organizing this webinar, to all our attendees who have been so kind to join in with us, listen in, send in their questions. And I think there's a message that the audience also wanted to hear Dr. Prabhu Desai's answer with regards to the titration of rivaroxaban. Anything particular, Dr. Prabhu Desai, that you
See,
you would
I don't think it's Dr. Soni told is absolutely right. In DVD thromboembolism, we generally give 15 milligram twice a day for 3 weeks or 20 days, and then 20 milligram we continue for a long period of time. If you have proven thromboembolism diagnosed.
Okay. All right, sounds good. So if there are any closing statements that y'all would like to give our audiences, this is your opportunity to do that. Again, a special thanks to Mr. Sailesh, to Mr. Shastri, to the entire Hetero team, Rishi, Manohar, all of them for doing a fantastic job.
I think I would like to
organizing this.
add one thing which we have not really covered.
Okay.
Is all this patient of COVID, which is moderately severe, whether they have got a neurological manifestation, whether they have respiratory manifestations, or whether they have to be referred for a pulmonary or a rehabilitation program. Okay, and I can tell you they get a tremendous benefit. Okay, and which include in this rehab program. We must include yoga and pranayam also, and meditation also. I think large number of anxiety, depression, and post-COVID brain fogging and other syndromes, especially fatigue, etc., can be taken care very well with the meditation. And this is, I can say, my experience. I'm talking to you, and there is a data on that as well.
I 100% agree with you, Dr. Prabhu Desai, and I think that in my last slide where I talked about immunity boosting for our doctor friends and also for our patients, I had included yoga, pranayam, and meditation, and I am a big believer in it. And I believe that in post-COVID phase, when a person has gone through something like that, potentially was a life-threatening experience, even if it was mild or moderate, the fear of death is very much 100% there, even in people who get it mild. We have all seen it in our practices, and I certainly have. And I think that learning to go back to our roots and to some of our ancient traditions with diet, lifestyle, meditation, prayer, yoga, pranayam, and as you said, the right kind of pulmonary rehab exercises where necessary with the help of a physiotherapist is extremely important for recovery and for regaining the strength that the person may have lost battling such an infection. So a very important point, and thanks for highlighting it. I think it's as important as it can be, as everything else that we've discussed. So thank you. Dr. Chafle, Dr. Soni, any closing comments before we end? We are almost at 9 o'clock.
No, thank you, Hetero team, basically, Dr. Sitesh, for taking very nicely through all the topics and all the questions that were coming when we are discussing things, basically. So yeah, we have covered literally every part of it, from the lung point of view to the intensive care and the neurology. And I think it was a good discussion. I enjoyed a lot. Thank you.
Great. Thank you. Thank you, Dr. Chafle, for your insights and knowledge. Thank you, Dr. Soni. Thank you, Dr. Prabhu Desai. Thanks to the Hetero team. And I think we can sign off and call it a day, and wish all our doctor colleagues a safe, healthy practice. Take care of yourselves first. Jaan hai to jahan hai. So do take care of yourself and your families, and definitely we'll do everything we can to take care of our patients also. Have a blessed night. Take care.
Okay.
Thank you.
छान